Hi everybody. We're going to wait a few seconds for everyone to get logged on and then we will get started. Okay, hi everybody. Thank you for attending our April RDLA legislative webinar. For today, we have a great lineup for you guys. If you would prefer to call into the meeting, you can do so using the number on the screen. For those of you who are joining us on the phone or if you're on your laptop, if you have a question, go ahead and type it into the Q&A box. And Adrian is going to be on the lookout for your questions and help get those answered. Just a reminder, in case we do have any media joining us today, we ask that you formally announce your participation and that you refrain from quoting any of our panelists directly. We encourage you to contact them for direct quotes. We also have closed captioning available for those of you who would like live transcription services. Just click the button on the bottom of your window that says live transcript to begin the transcription. We also have Spanish translation services available, and Adrian just posted a link in the chat box that you can use to pull that up if you would like. So again, here is our agenda. We're going to get some really exciting Rare Disease Week updates from Shannon. And then we are going to hear about the status of rare disease appropriation priorities from Jamie Sullivan from the EveryLife Foundation. We are then going to move on to discussing access to genetic counseling, the Service Act from John Richardson at the National Society of Genetic Counselors. Then we are going to hear from Heather Ferguson of the Lymphedema Advocacy Group about the Lymphedema Treatment Act. And then lastly, we are going to hear from Shanna from California Assembly Member Brian's office about a bill that they have in their General Assembly right now. So first off, I will kick it over to you, Shannon.
Great, thanks. I will be super quick so we can get into all of these meaty topics. But as many of you probably already saw, we announced a few weeks ago that Rare Disease Week on Capitol Hill would be virtual this summer. So it's new dates, new format, but we're hoping to provide the same life-changing experience for all of our advocates. And the dates are July 14th to July 22nd, and registration opened yesterday. If you didn't get that email, you can access the registration page at rareadvocates.org/RDW. So just a quick overview of the agenda for the week. Like I said, we're hoping to be able to provide a similar experience with the learning, the networking, and advocating that would normally happen in person here in Washington, D.C. We know how important all of that is to the experience. So on July 14th, we will have a virtual Rare Disease Caucus briefing and the documentary screening that evening. And then on July 15th, we'll have our virtual legislative conference, day one, and the Rare Artists Gallery, a very cool virtual gallery, will open. On July 16th will be the second day of legislative conference. And these are, 3-4 hours, not full day of legislative conference to accommodate. We know how busy everyone is. And then the YAR Leadership Academy graduation will happen that evening, along with the YAR meetup for our young adult advocates. And then the following week, starting on Tuesday, July 20th, we will have our virtual meetings with representatives on the House side, followed the next day on July 21st with virtual meetings with senators. And then on July 22nd, a new event diversity roundtables. And of course, on the registration page, you can choose which events you'd like to attend. And of course, with the meetings with representative senators, you can choose whether you want up to the 3 meetings with your own representative and senators, or 4 or more meetings. So you can have some choice and flexibility in how you participate during this week. And so here are some important dates to remember leading up to Rare Disease Week on Capitol Hill. The registration will close on June 18th. And then, as always, we will provide training webinar for Rare Disease Week on June 22nd. The team coordinators webinar will be on June 29th. The new attendees webinar on July 1st, and the Fast Forward for Rare Practitioner Pitch webinar on July 8th. And then again, we're going to provide some virtual office hours, so you can mark your calendars. These are just opportunities to ask questions before Rare Disease Week begins that might still be lingering after all of these webinars. So July 12th, we'll hold a special one for the team coordinators, and then 2 others for all of the advocates on July 13th and July 19th. Next slide, Caitlin. Oh. And then I just want to do a quick thank you to our Rare Disease Week Advocacy Chair and Vice Chair. You might have seen the registration email came from Tanya Prince. So Tanya Prince and Sarah Tompkins are Advocacy Chair and Vice Chair for this year's Rare Disease Week, and helping work behind the scenes, organizing and planning this year's event. And so we're really thankful for their participation and assistance.
Great. Thank you so much, Shannon. We're now going to hear from Jamie Sullivan. Jamie, are you ready?
Ready to go.
All right, perfect.
Okay, great. So you can go on to the next slide, and one more. So hi, everyone. I just wanted to give you a little bit of an update on where we are with the appropriations process, both in general and specific to the rare disease priorities that the EveryLife Foundation put forward. Those of you who participated in Rare Across America might be familiar with some of these priorities. Thank you to those who included them in your meetings, and we had some really great follow-up from those sessions. So where are we now in general with the whole process? As you know, not unexpectedly, the process is a bit delayed and still evolving. The first step when there's a new administration is often a little bit delayed, and that is the administration's budget request. So recently, the Biden administration released what we call a skinny budget, or a very high level set of details on some of their budget priorities. And I say very high level. There was not a ton of detail on some of the programs that we care and the agencies we care most about. However, one good sign that was in that was an increased investment in medical research, including this new proposal, which we'll be looking at in further detail around the HARPA medical research proposal. So we are still lacking a ton of detail, and the administration should release a new budget budget proposal shortly, hopefully. Well, timeline is still yet to be seen. The administration and the congressional Democrats are still working to determine exactly, go back one more, sorry, to determine how they're going to use the budget resolution and reconciliation, which is a slightly different process to advance priorities outside of the normal appropriations process. Like I'm sure you've heard a lot of conversation about infrastructure bills. They have, however, begun the FY22 appropriations work. As a reminder, FY22 will start on October 1st. So, the ideal scenario is that we have all of the appropriations process done by October 1st. As you'll hear later, that's highly unlikely to happen, but The committees have subcommittees. So there's 2 subcommittees that we generally will work with: the labor HHS committee and the agriculture and FDA subcommittees. Both are the committees that handle the issues related to health and medical research and FDA funding. Some of those committees have been holding hearings to hear from the agency heads and cabinet secretaries about their priorities. The House has changed the rules this year and is allowing some limited earmark requests, a throwback to previous decades. The House appropriations request deadlines are next week, which means that these are the deadlines for members of Congress to submit their own priorities to the subcommittees, the appropriations subcommittees, indicating what they want to see in it. So that's why it's so important that so many of you spoke up about these rare disease priorities, and then the EveryLife Foundation team has been following up with formal submissions to offices, urging them to include these issues in the priorities they submit forward to the House appropriations committees. The earmark policies on the Senate are going to be a little different, and the Senate submission process is lagging, behind the House as usual, and the deadlines are still somewhat unclear. Next slide, please. So what does this mean now? The delayed budget and late start and deadlines, they'll likely impact the typical bill development and markup schedules, but a lot is still remaining to be seen. So we'll pay close attention and keep people updated when there's opportunities for advocacy efforts. The committee staff are doing their groundwork and reviewing the requests we've put in, meeting with stakeholders, so we continue to pound the pavement and stress the importance of rare disease research and FDA funding requests. So next slide. So what did we put forward in the final request? Those of you who did participate in Rare Cross America will notice it looks slightly different, but really the same core issues, only we split the NIH into 2. So you see 4 submissions, and these are tiny print. I just wanted you to have the actual language. So our focus was really on FDA, NIH, and CDC, specifically with CDC, the National Center for Health Statistics. So I'll go through each one really briefly, but with FDA, our ask was to fully fund up to the authorized amount the Office of Orphan Products Development Clinical Trial and Natural History Grant Programs. These grants offer a lifeline for unmet need in the rare disease community, clinical trial methodology, natural history studies that are so sorely needed to spur drug development later on. And the program has not received an increase in years. And so our request was to include this language and a funding amount of $30 million for FY22. And moving over to NIH, we decided to split out the focus so that we really called even more attention to the work of the National Center for Advancing Translational Sciences. The rare disease research that NCATS does is cross-cutting. It's it's platform-based research. It's the Rare Disease Clinical Research Network, and it can really accelerate rare disease research across the board and allow us to capitalize on the advancements that we've all seen happening in the evolution of science in rare diseases, and make sure that we can get towards more treatment and cures for the 93 to 95% of rare diseases that don't have any. So our core focus in this language was to encourage NIH to dedicate more funds, specifically via NCATS, to rare disease research. You also see in the Office of Director, we have called out the Undiagnosed Diseases Network. This is a really important program that has been funded for the last 9 years from the NIH Common Fund. Unfortunately, projects funded via the Common Fund have a 10-year funding limit, and now it's really important that the Office of the Director understands that Congress wants them to find a solution and a home for this important network to continue. So basically they have to now be be funded via mechanisms available in the different agencies of NIH in order to continue. Otherwise, their funding will run out next year and they will have to stop accepting new patients. And we know that there's so many in the community that have been served by this network, and that they've given them hope where they had, you know, lost hope of finding the right diagnosis in the past. So we want to see this continue. And then lastly, the CDC, National Center for Health Statistics. This is language that is designed to spur the agency to begin looking at how ICD codes can be obtained for rare diseases in a process that is more efficient, less complicated and timely and costly, so that patient advocacy organizations who are often left to navigate this process can more easily obtain an ICD code, which has a whole host of effects on getting the correct diagnosis, population, you know, health data tracking, treatment access, and more. So we really hope that we'll see this language included in the final report, and that CDC will take it seriously and act upon this initiative. Next slide. So where are we now? We, like I said, priorities were included in many Rare Cross America meetings. The co-chair of the Rare Disease Caucus, his office has provided all of the caucus staff contacts with a template letter that they can use to include these priorities with their own requests. And so we're hopeful that many caucus members will carry forward the 4 priorities within their submissions to the committee. We've submitted many formal requests. Many offices have forms officially that you have to fill out justifying why you want this, why you want to see the language, what you exactly want to see done. And we've even worked with some of you to get those forms submitted. And I'd love to see all of the interest that's been shown in getting involved in the appropriations process so far this year. It's been great. Right now, we're just identifying the next steps for our advocacy efforts based on how the process proceeds, and we'll definitely be communicating more as we go. Whenever there's a timely opportunity for, you know, weighing in via an action alert or calls or meetings with your members, we will certainly be reaching out when that occurs. And next slide. And lastly, if you are interested in learning more in general, just about appropriations, advocacy, and the process, Caitlin and Shannon and the team have created a really excellent tip sheet that's now available as of today on the RDLA site, and I included the link there. And then our partner, Nick Minetto, back in November gave a really comprehensive overview of the appropriations process and why it's important and how it works. And that video tutorial is also up on the RDLA website. So I encourage you to check out those resources. And if there are additional questions you have, I'm happy to answer them. And that's it for me.
Great. So let's see. Does anyone have any questions for Jamie? I'm looking in the Q&A box. And I'm not seeing any at the moment. So if anyone does think of any questions for her, feel free to email her. And you will have access to these slides on our website after the webinar. So you'll be able to find her email address there. Thank you, Jamie.
Thank you.
Yeah. Now we are going to hear from John Richardson.
Hi, thank you for the opportunity to talk about HR 2144, the Access to Genetic Counselor Services Act. You can go to the next slide, please. So the bill is really an important component to try to drive towards the triple aim of delivering genetic services. You know, we have really great data that demonstrates that when genetic specialists are involved in the delivery of genetic services versus the non-genetic professionals, you know, quality increases and costs go down. And so a lot of good peer-reviewed literature that hit both those points. And so the real missing piece is better access to the genetic specialists. Over the past, there's been a workforce shortage that has changed significantly over the last 5 to 10 years, where the profession of genetic counselors has doubled in size. Now there are about 5,000 genetic counselors, so roughly one for every 75,000 individuals in the United States. And so right now it's not necessarily a workforce issue, it's more a policy issue. And so our bill would significantly improve access to genetic counselors because they'd not have to practice under the current rules, which really does impact it. And the other thing with access too is, you know, for every patient that sees a genetic counselor, the entire family is often benefiting, which is kind of unique to genetic services. So that's an important point, that they, you know, focus on families and not just the patient in front of them, which is what, you know, most healthcare professionals are doing today. You can go to the next slide, please. I think you skipped the slide. Yeah, right here. Thanks. So this is kind of the current environment of how genetic counselors see Medicare beneficiaries. Because they don't have provider status, they have to follow Incident 2 rules. And that requires a physician to supervise them as they provide their services. The physician actually has to be under the same roof as the genetic counselor. And so you need to coordinate schedules with the patient, genetic counselor, and the physician. And so that complicates things, and it creates barriers. The supervising physician would build a service under the current fee-for-service Part B Medicare program. And so they're getting paid the full amount of what the physician would get as if they delivered the service themselves. And obviously this is creating an inefficient service delivery and is impeding referrals to genetic counselors. And the reason why we say it impedes referrals is because a physician that doesn't work alongside a genetic counselor today would need to refer patients to another physician that actually is working with a genetic counselor. And those referrals just don't happen because the physicians are worried that they'll lose that patient to the physician that they're referring to. What the bill will allow is referrals directly to the genetic counselor. So physicians won't have that fear of losing patients. Next slide, please. So this is just an example of the existing non-physician practitioners that are currently recognized, have status under the Medicare program. And so, you know, it's a lot of specialists and genetic counselors really should be on this list, and our bill would obviously correct that issue. Next slide. So HR 2144 was introduced about a month or so ago by Representative Brian Higgins of New York. In the previous Congress, it was introduced by Dave Lubsack of Iowa. He retired, and so we have a new champion this year. Mr. Higgins sits on the Ways and Means Committee, which is great. The bill has been referred to two committees. It's the Energy and Commerce Committee and the Ways and Means Committee. So both the health subcommittees in those two respective committees will hopefully take action on this bill this year or next. That's a current list of co-sponsors. We really haven't ramped up the grassroots yet. The grassroots will really start ramping up, I think, next week. We're grateful that we have over 250 organizations supporting the legislation. Thanks to all of you that are supporting it. You know, we can't do it without, you know, effective patient advocates, and that's certainly who you all are and who you represent. And so that's greatly appreciated. You can go to the next slide. So this is just a high level bill summary. Essentially what the bill does is it provides Medicare status for the genetic counselor so they can be reimbursed. So as I said, currently, you know, they have to provide services under these Incident 2 rules where the physician's billing the service and they're the ones that are getting reimbursed. This actually will pay the genetic counselor directly. It will follow state licensure in terms of the scope of practice of the genetic counselor. We have licensure at the end of this year. We'll probably have licensure in about 35 states. And so, you know, counselors would practice under that state scope of practice. For the states that don't currently have licensure, the Secretary of HHS would actually set criteria through regulation in terms of who would be considered a genetic counselor. and what they could actually do. Genetic counselors under the bill would be paid at 85% of the physician fee schedule. And so, as I said, physicians today are getting paid at 100% of that fee schedule. Genetic counselors would get paid at 85%. That aligns with the nurse practitioner model and many of the other non-physician practitioners. That should yield some actually cost savings. The unique thing about our bill is we're actually not adding genetic counseling. Genetic counseling is currently a covered benefit under the Medicare program. And so, you know, with paying genetic counselors that 15% less should save money, and that'll be of big benefit when we're trying to move this bill on the Hill. Also, the bill would allow genetic counselors to provide telemedicine services. During the pandemic, we've seen a significant disruption of services as, you know, hospitals were trying to mitigate exposure to the virus. Many genetic counselors were moved out of the clinic and to their home to provide services through telehealth or through the telephone. And that worked out really well for most payers. They allowed it, but for Medicare, we couldn't get a waiver because they're not recognized. So there was kind of nothing to waive in the statute. And so for Medicare beneficiaries, they've actually had to have gone to a clinic to receive these services and risk exposure. And what we've seen is a lot of people just wouldn't take that risk and went without services, which is true for a lot of things within healthcare during the pandemic. But we were definitely significantly affected by that. The other key thing is that it's not going to wall off the service. So if a physician feels comfortable providing these services, or a nurse practitioner you know, is comfortable providing genetic counseling, they would still be able to do that. So it's not precluding others from providing the service. Next slide. So, you know, we talk about this in terms of just it's modernizing Medicare. The statute has not kept pace with the innovation that's occurring. Obviously, in the testing space, there's new tests that are being brought on the market daily. It's amazing how much innovation there is. We need more of it. And so, you know, this will allow better access to the genetic counselors. And when they have, you know, when patients have better access, you know, families benefit. It should provide cost savings, as I said, and it's going to provide savings in terms of the actual genetic counseling service. It could also provide a lot of savings on the testing side, because we see that when people see a genetic specialist, they're more apt to receive the right test, and obviously that could save significant dollars. The GAO and the Inspector General has actually highlighted genetic lab services as being a major concern because of the spending increase in this area. And so it's really important to make sure that that when people are ordering testing in this realm, that it's the right test. These tests are obviously very expensive, or they can be, and you know, Medicare doesn't want to spend $30,000 on a test when actually, you know, a $500 test is the most appropriate thing to order. So the other thing is, because I know obviously rare diseases affect, you know, at least 50% are children. And so we really believe that in terms of access, this bill will have a significant impact, because there are a lot of hospitals out there that can't afford to hire a genetic counselor today. There's no revenue from Medicare directly to the genetic counselor. And so they can't justify hiring a genetic counselor from just an operational standpoint. And so we believe that, you know, more hospitals with a new revenue stream will be actually hiring genetic counselors. And obviously, if a genetic counselor isn't on staff at a hospital and then is on staff, they're going to see non-Medicare patients as well. So we really think that this will increase access to the non-Medicare population. Obviously, it'll affect Medicare directly, but I think indirectly it'll also affect, you know, the non-Medicare eligible patients. So with that, I am happy to take any questions.
Great, thank you. Let's see. All right, so there are a few questions for you in the Q&A box. So one question is, are we able to add ABA therapists to that list?
You would need to actually introduce a bill just like what we're doing. And so, you know, I know like chiropractors are trying to receive Medicare status. Acupuncturists are out there, I think, preparing bills that would allow them to have status. And so generally, unfortunately, this is done by piecemeal. Part of that is the cost issue. And so, you know, as I said, for genetic counselors, the genetic counseling and the generic term genetic counseling, it's already covered. So we're not adding a service, and adding the service is what really adds to the cost of legislation. And if things cost a lot of money, you know, it's harder to move those bills. And so that's why, generally speaking, this is done piecemeal. They certainly could, you know, move forward and try to gain status. But they'd need probably to introduce a standalone bill to do that.
Okay, and the next question is, would patients be responsible for the other 15% of the bill for genetic counseling?
Yes, generally speaking, it depends. It depends on your coverage, and obviously, if you had Medigap insurance comes into it. But there may be some co-pays, co-insurance, depending on the plan and additional Medicare coverage, essentially. But this is focused on fee-for-service Medicare. So it's not on some of those managed care programs, which the managed care Medicare programs can actually, and some do actually, cover genetic counselors today, because they can set up their benefit packages and they have a lot of freedom to do that. So this really is focused on fee-for-service, and generally speaking, you know, physician services are susceptible to the co-pays. Lab services aren't. The lab services are paid at 100%. There's no co-pay, co-insurance there.
Great, and you have a couple of questions actually. So the next one is, how would the bill impact Medicaid and the patients covered by it? Is it going to influence Medicaid as a whole, or would it be implemented on a state-by-state basis?
Yeah, it's the latter. You know, we see some states have some decent Medicaid coverage today. We do believe that with Medicare recognizing genetic counselors, that probably will trickle down to the states. And so if you have states that aren't reimbursing genetic counselors, the odds are that, you know, things will change, because Medicare definitely has that influence on the state Medicaid programs. But states generally have a lot of latitude in terms of what their program actually covers and what it reimburses. And obviously, you know, we're out there at the state level to some extent working on coverage, and certainly if this bill was to be enacted, a lot more of our effort would be redirected to the state level and the Medicaid programs for sure.
Okay, and the next question is, would this bill assist in getting the funds to have geneticists back into regional centers? This person stated that funds were cut and genetic counselors were some of the first to go because of budget cuts.
Yeah, we hope so. I know we focused on the regional networks quite a bit. You know, there are a lot of genetic counselors around the country with leadership positions in some of these networks. I think that, you know, we need to get better access at the community level. You know, the wait times for geneticists are just unsustainable. Unfortunately, you know, there aren't as many physicians going into that specialty as we'd like to see. So, you know, I think that certainly this bill will help, because again, there'll be an additional revenue stream that'll be coming from the federal government, and I think hopefully more people will be able to employ genetic counselors, and actually genetic counselors will be much better suited to open up private practices where they could serve, you know, a large swath of a region, as a genetic specialist hub, if you will, receiving referrals from all over a region. And so we think it'll impact, access broadly, and that would certainly include the networks. It's not going to have a direct, effect on those networks, but that's something that we're also looking at that's separate from this bill is how are those networks working and how can we make them more effective, and certainly funding is part of that.
Great. Okay. And there are a few more questions for you in the Q&A box. If you want to go check those out, we're going to move to the next speaker. Thank you so much, John, for your presentation and for answering all these questions.
You're welcome. Thanks for the opportunity. I really appreciate it.
Absolutely. So next, we are going to hear from Heather Ferguson from the Lymphedema Advocacy Group.
Thank you so much. So I'm whoops, can you go back to the first one just for a second? There we go. So I'm the founder and director of the Lymphedema Advocacy Group, and I became involved in this because I have a son who's now 14 years old who was born with lymphedema. And when he was prescribed his first compression garments, we learned that there's a lot of trouble with insurance coverage for these medical supplies, all stemming from the fact that Medicare doesn't cover these supplies. So much like the issues that John was just talking about, because there's no Medicare coverage, all of the other coverage is really spotty. So we are working on a bill called the Lymphedema Treatment Act, which would mandate coverage for the Medicare program to cover compression garments, which are the key item to treat and manage lymphedema. And in doing so would set a standard for private insurances and state Medicaid plans to follow. So our hope is that this will, broadly improve coverage across the board, but wherever gaps might remain after this federal bill is passed, we would go and then direct them, address them with state legislations or by working with individual insurance companies. But Lymphedema Treatment Act is the name of the federal bill. And if you go on to the next slide, I'll give you some background information. So primary lymphedema, like my son has, is a rare disease itself, but lymphedema is also a common co-condition with 40 other rare diseases. And our group has heard from a number of other families where they express that even though lymphedema is not their greatest, perhaps, health challenge to their child, it is the most challenging in terms of accessing care for it because of the problems with the insurance coverage for the compression supplies. So if you go to the next slide, we've been working on this bill for a while. In the last 2 cycles of Congress, it was actually the most supported healthcare bill. Last year, we finished with 386 House and 71 Senate co-sponsors for a total of 85% of Congress co-sponsoring the bill, which is really, really incredible. Our bill was also passed in the House, but unfortunately not taken up by the Senate during the last Congress. But with the changes in leadership in this Congress, we're optimistic of our chances of getting through both chambers and seeing the bill signed into law. You can go to the next slide. So this is an exciting day for us. Our bill is probably going to actually be introduced this afternoon in the Senate, which is just a coincidence with the timing of this webinar. But noon today was the cutoff for original co-sponsors to join the bill. So as of my last check-in with our lead sponsors' offices at about 11 a.m., we had an incredible 33 Democrats and 21 Republicans for a total of 54 original co-sponsors. So initially our leads were considering only putting them on in bipartisan pairs for introduction, but they ended up deciding that they're going to go ahead and allow everyone on as originals because it's just so impressive to already have a majority on the bill at the time of introduction. I'm also pleased to let you know that Senator Chuck Grassley is returning as our Republican co-lead for this Congress. So Maria Cantwell of Washington State has always been our lead sponsor. She introduced the bill initially with Chuck Grassley, but last year when he chaired the Finance Committee, He took a hiatus on leading our bill, as is typical for chairs of the committees to do when that bill falls under their committee's jurisdiction. But this year he is returning to lead the bill with Senator Cantwell. And like I said, we expect that it's probably going to be introduced by the end of the day today. Our House bill is hopefully not far behind, and our lead sponsor in the House, just like the last Congress, will be Congresswoman Schakowsky from Illinois. And just as a reminder that all of those co-sponsors that we had gathered in the last Congress and the fact that we passed the House in the last Congress does not carry over to the current Congress. Unfortunately, you're always starting from scratch. But as is demonstrated by the number of original co-sponsors, we have typically once a member of Congress supports a bill, they're very likely to in the next session as well. So we hope to really get off to a strong start in the House as well, just like our Senate bill. And like I said, hopefully see that the bill move through both chambers during this Congress and be signed into law. If you can go to the next slide. So I just want to remind you how much of a difference it makes for you to contact your members of Congress. These 54 original Senate co-sponsors were not gotten by our organization. They were gotten by hundreds, maybe thousands, because it's impossible to track the number of phone calls made, but by many, many constituents reaching out to their own senators, asking them to be original co-sponsors of the bill. So if you have not been an active advocate before, you don't realize what a difference your phone calls and your emails and your outreach makes. It is huge. It is everything. You are the people that can vote for them. They would much rather hear from you than from me. So constituent contact is so important. So I encourage you to all head over to our website when you get the opportunity. We have advocacy forms that make it really easy for you to email your members of Congress, and the list of phone numbers for all the offices and a simple call script and everything. So it's really easy for you to reach out to them. We definitely want everybody contacting their senators now that the Senate bill is going to be reintroduced. If you are fortunate that one or both of your senators are among the 54 originals, then it's great to call and say thank you. Offices always hear from people when they want something or when they have something to complain about, but they don't always hear when somebody is happy with something that they've done. And it stands out, and it really helps us to build a good relationship with these offices, because co-sponsoring is really just the first step. Now we need for them to work to get the bill into a package and vote for it and signed into law. So even if they're already co-sponsoring, it's still very valuable for them to hear from you. And perhaps as early as next week, we'll be ready to reach out to House offices, and then we'll need your help reaching out to your House members as well. So thank you for everyone who has supported this bill in the past, and we need you to continue to do so, and we really hope that this is our Congress to get across the finish line. So I'd be happy to answer any questions.
Perfect. Heather, thank you so much. There's one question for you in the chat box. What advocacy strategies did you use to get so much support for this bill?
It's really been all about training people to be good advocates. Like I said, in the early years, we were starting from scratch. So I would personally contact all 100 Senate offices and every House office. And that had its value too, but you don't get this kind of volume of support without constituents reaching out. So it's really been the years that we've taken to really first just get people to find the courage to contact their office. I think a lot of people find it intimidating, and they don't realize that it's nothing to be intimidated about. They hear from people calling in all the time, so just do it. It's not scary. And then helping them to really find their voice as an advocate, so that what they're sharing when they do pick up the phone or send an email is really constructive and helpful to getting that member on board. So I would say that's my best advice. And never give up. I guess I have to include that, because I think some people think that one phone call or one email is that they've done their part and they're done. And that's not at all the case. It usually takes many phone calls and many emails from many people to get a member on board. So persistence is important, and remembering that you're not pestering them, if you call every couple of weeks and you're polite about it and you're providing them with valuable information, I don't think most people realize that the health aides who keep track of these bills have thousands, by the end of a Congress, thousands of bills that they're tracking, and it's impossible for them to keep them all in the forefront of their mind. And so a friendly, helpful, constructive call is what they need to keep the issue on the front burner.
Perfect. Well, as always, thank you so much, Heather. We are going to move to our final speaker, and that is Shanna.
Good morning, everybody. My name is Shanna Ezzell. I am the Capital Director for Assembly Member Maienschein. Out here in California, represents the 77th Assembly District in Northern San Diego, and is co-chair of the Rare Disease Caucus. And before I dive into what I'm here to talk about, I just need to say I've been sitting here nodding along with everything Heather just said. So from the perspective of a legislative office, ditto to everything she just said about grassroots advocacy, and especially calling to say thank you, because she's right. We only hear from folks when they want something or they're angry about something, and those thank yous actually really do make our day and make the members' day. So everything she said, yes. So I'm thrilled to be here with you guys this morning to talk about Assembly Bill 114 that Assembly Member Maienschein is authoring. The bill is a continuation of an effort that he's been leading for a few years that began in 2018 with what's called Project Baby Bear. Some of you on the call may be familiar with Project Baby Bear, but that was $2 million was allocated from the California state budget to examine the benefits that rapid and ultra rapid whole genome sequencing could have for babies on the Medi-Cal system, and explore the hypothesis that employing this innovative precision type diagnostic tool at the beginning when a patient is experiencing unknown or symptoms of unknown causes can eventually become a long-term cost savings and also achieve tremendous benefits for the patient if it's applied early as opposed to later after diagnostic processes have proved. It's early here. I'm still halfway in my first cup of coffee, so I'm sorry. But when tests are proving ineffective, that's usually when genome sequencing would be turned to. So what if we flip that on its head? What if we started with genome sequencing when a baby has come in incredibly ill and you can't immediately figure out the cause, or the symptoms that they're presenting with are severe? Some of the cases that are often talked about are seizures, where a baby is seizing constantly and you can't get them to stop. So Project Baby Bear was intended to sequence 100 babies at 5 children's hospitals across the state of California who treated Medi-Cal patients. The intent was to have a turnaround time around 3 days of genome sequencing, and look at the whole makeup of the baby's DNA and comparing it with the parents if the parents were available to be tested as well, and see if there was a genetic cause that would explain the symptoms. With the $2 million, it was spearheaded from Rady Children's Hospital in San Diego. They were able to kick in a little bit extra, so they succeeded in sequencing 178 babies. They diagnosed 35 rare diseases, found 513 fewer hospital days, were able to eliminate 11 unnecessary surgeries, and had around a $2.5 million cost savings to the Medi-Cal system. And the theory is that over the long-term life of the patient, that those cost savings are going to just continue to grow. And we just don't have the data for it yet. So building off of the success of Project Baby Bear, our goal is to have this test be a covered Medi-Cal benefit. Because right now what's happening is a lot, because it's a significant, cost to the test, and a lot of facilities are covering it on their own just to make sure that the patient has this benefit. And we're starting to see, beginning with Blue Shield, we're starting to see some private insurance companies cover that. But funding, having facilities and donations cover the cost of the test for Medi-Cal patients is just not a sustainable strategy, and it creates a health disparity. So we are seeking to have that be a covered benefit under our Medi-Cal system. And that's what Assembly Bill 114 is. It would make this a covered Medi-Cal benefit for babies who are babies less than 1 year old who are receiving care in an intensive care unit. So the thought is very critically ill babies where time is of the essence. We're also working on a corresponding budget request since covering under the Medi-Cal program will take state funding. We just were heard in the Health Committee last week. We received unanimous support, but unanimous and bipartisan support, which we're thrilled about. And we are next moving into our Appropriations Committee. And this is in California, it's a little different than on the federal side. Nothing is actually appropriated in our Appropriations Committee, but what they do is they look at the overall fiscal impact of the bills to the state budget. We are going on to what's called the suspense file, which is everything with a cost impact of $150,000 and higher. They look at everything kind of in one snapshot because unfortunately we don't have the budget to fund every bill that's been introduced. So they make a determination of what we're going to try to fund this year versus not. Some bills will make it off, some bills won't. And that hearing will happen on May 20th. So what we're working on right now is building support, from organizations, from grassroots, like Heather was speaking about, and just letting, the committee and the state know how vital this testing can be and how much of an impact it can have to the lives of the patients, to the state overall, and to doctors who are trying to help treat these patients. It can, the final report from Project Baby Bear had a lot of different case studies where they were, either able to find the rare disease immediately. We're seeing turnaround times at this point of 12 hours for genome sequencing, which is unheard of. It's a test that used to take weeks. We're now getting turned around in hours that can bring a immediate diagnosis. That some case studies were showing that rare genome sequencing was finding that the baby was just deficient in over-the-counter vitamins that they wouldn't have been able to find out that quickly or necessarily have thought of right away. For others, it maybe didn't produce a diagnosis, but helped the families transition into more palliative care options and be, I guess, have more faith in the information they had in moving into that difficult decision. So there are just, so many different options and benefits that can come from this testing. The goal here for us is mirroring exactly what Baby Bear did and trying to take that data-driven cost savings, have that applied in the state budget, and then hope in the future that opens it up to being able to cover this for more patients. But we're starting with the most critically ill, the ones that can impact the most, hopefully have the most long-term cost savings, and then are hoping from there that that'll start the path forward. So I'm going to drop a couple links in the chat. I'm going to drop a link to our fact sheet for the bill, a link to, they have this advocacy portal system where you register an account, and that's how you can show your support. You can show your support as an individual, or you can do that on behalf of your organization. And if you do that, there will be a letter needed. That will be there, as well as our website where you can follow updates about the bill. And then my email will be there as well. So I am happy to answer any questions today, or if you have any questions going forward, would like to submit support and need help figuring out how to do that. Sometimes the portal is not very user-friendly. Happy to help how I can. But yeah, excited to present this to you today, excited to be working on it. We're very, very hopeful. Medi-Cal funding is always kind of the pot of funding that everybody's looking at to get things covered. So we know that we don't have a certain path, but we're very hopeful that the data that was shown in Project Baby Bear will give us a good chance, but definitely grassroots support, knowing from people in the field how important and effective this is, will go a long way. So with that, happy to answer any questions.
Shayna, thank you so much for your presentation. We have one question for you in the Q&A box. Would any of the details in your bill also be covered by the HEART Act, which is a federal piece of legislation?
I am not, to be honest, not fully familiar with what's going on the federal level on this. I know that there have been some efforts on the federal level to do something similar. I'm not familiar with the particulars of that piece of legislation to be able to give you a definitive answer today. because oftentimes state and federal move at different paces. But I'm happy to take that question and can look into the specifics of the answer.
Perfect. Well, thank you so much for your presentation. And if anyone has any questions, feel free to email Shayna. We appreciate you being here with us.
Of course, happy to.
Yeah, just a few reminders for everyone that is still here with us. The RDLA Advocate Survey closes this Friday. We are very grateful for everyone who has already participated, but if you have not yet participated and would like to, Friday is your last day. The link is here on this slide, and a recording of this webinar, like I said earlier, will be posted on our website by the end of the day, so you can find the link there as well. We also have some really exciting new RDLA resources on our website. We have a glossary, and this glossary has all the terms that you need to know for your rare disease advocacy. And we also have some really cool new video tutorials on the appropriations process, Cures 2.0, and PDUFA. So be sure to check those out for more details. And lastly, we ask that you save the date for our next monthly webinar that is going to be held on May 20th. But before that, this month, we are also hosting another webinar specifically to state advocacy. This is going to take place April 29th at noon, and you can register for the state webinar on our website right now. The link is there and live for you to register. So we hope that you are all able to join us for both of these two upcoming webinars. And as always, we really appreciate our sponsors for today's April webinar, and we appreciate you all for being here with us. And one last thank you to all of our panelists. You all did such an amazing job. As always, we appreciate you being here and sharing more information with us on your bills and what you are all working on. So thank you, everybody, for being here. I hope that everyone has a great rest of the week.
Thank you.